So we've been called to a 40-year-old male who has fallen significantly off a roof today. On arrival, he's obviously landed on his head and he's got a big boggy patch at the back there. We've done our initial first and secondary surveys and we have found no other injuries except for his head injury. He has a lower GCS which we've put at 5 and he's quite combative. He's got rigid extension, which is all indicative of a brain injury. We haven't collared him, but we've put towels either side of him. We've oxygenated him and we've taken some vital signs, which are a heart rate of 50 and a blood pressure of 160, 110. His rest rate is 12 but irregular, and his BGL is 7.6 and his temperature is 37. So my suspicions is that this patient has a traumatic brain injury. And with that initial assault comes swelling within the brain. From the swelling within the brain comes a release of CO2, which causes vasoconstriction. With that vasoconstriction, it impedes blood flow and increases the CO2 as well, which then leads to intracranial pressure, leading to tissue death or cell death, which then of course releases more CO2 and causes further vasoconstriction and cascading as the patient deteriorates. If you think of the brain within a box, as it swells, it can't go any further. So what happens then is it can only go one way, which is down through the spinal cord, which we call coning. With the patient's vital signs, this is telling me that due to the increased blood pressure and the decreased heart rate, that with the Cushing's triad that we learn, it's showing us that this intracranial pressure is now having this effect on the patient. So what we want to do, of course, is we want to call for an RSI capable paramedic, because we want to prevent a secondary injury for this patient. So I've already called for an R50 and they're 10 minutes away. So in that time, we're going to set up for intubation for them. With the patient being slightly combative, I'm giving him small increments of morphine just to keep him nice and calm. We have an airway adjunct beside him just in case he actually needs it. So let's go through our RSI checklist. So we need to attach nasal prongs without the oxygen. So I'm going to do that, but I'm also going to leave the patient oxygenated with the non-rebreather until we're ready to actually begin RSI. So I'll put that on him and put that back. Okay. So the next step, it says pre-oxygenation with a reservoir mask at 10 litres, which we're already doing. We've already got our monitor and blood pressure and SpO2 attached to the machine. So we want to prepare capnography, so we can do that. So we'll just pop that in here. And we'll just sit that on top of the monitor so we know where it is. So that's just showing us that it's reading. Monitor to be in a position that we can see, leaving space at the right side of the patient's head, which we've done. So that's just alarming because it's not actually attached. We have got large bore IV access in both sites, and I have already a running line of 0.9% sodium chloride. Okay, so we're going to then position the patient for optimal airway control. So we have towels either side because we've decided not to collar, but I also have a towel here just in case the ICP requires it. Place the ETT holder, so I can do that for them. So we'll just place that under his neck and have that all ready to go. Ensure our suction is working and turned off, which I have here, and I've just laid it right there for them to use. Prepare a mental ventilation bag with PEEP, which we have here, and I have PEEP attached at 5 for a TBI, and the reason we do that is because the way PEEP works is it increases the intrathoracic pressure, which also puts pressure on the superior vena cava, and it then impedes blood flow. So we want to keep it at 5 for brain injuries. We'll obtain another set of vital signs, so we can do that now, and we'll get in another blood pressure, SpO2, heart rate, and then we can update and let our ICP know if anything's changed or if the patient's conditions is the same. So we've made sure that the area is clear and free of any debris, so that the ICP has a good place to work. So then we want to move on to if we have a failed intubation, and so we'll just go through our checklist here. And so what I would suggest to do is, it says here unable to visualise chords within 15 seconds, so I could offer to time that for the ICP, as well as unable to intubate within 30 seconds of laryngoscopy, so I could time that for him or her to see if that's the problem. Then we would manually ventilate, and we would retry again with one bougie, and that's the bougie that I would assist with, hold onto it and place the tube over for the ICP if required. We would optimise position, so we may need to reposition the patient. We could use different blades, so I have laid out different blade sizes for the ICP. We could also use anterior tracheal pressure, so while the ICP is intubating, I could just add some pressure on the cricoid there just to get a better view. And of course, if that fails, we could place an LMA or anything to do with that, and if we were still unable to ventilate, then the ICP would have to think about a cricothyrotomy, which is a surgical incision into the patient's airway.